From Faith Forward Media, this is Healthcare Musings. I'm Dr. Hassaballa. Hey everybody, Hassaballa here on Healthcare Musings with another episode of Journal Watch. Happy to have you with me. All right, today we are discussing a systematic review and meta-analysis published in the Journal of Trauma and Acute Care Surgery, reviewing small versus large bore thoracostomy for traumatic hemothorax. So, as an intensivist, I do take care of patients that have suffered blunt and penetrating trauma, and sometimes there's bleeding in the intrapleural space, in the space between the lungs and the chest wall, and you have to drain that blood with a tube. Typically, you will drain that blood with a big tube, a very wide bore tube, because the theory is the bigger the tube, the easier it is to drain the blood, and blood can clot and clog, and so it's traditional thinking that a big bore tube, large bore tube, is better than a small bore tube. And according to the article, there are approximately 300,000 traumatic hemothoraces diagnosed in the United States every year, and so what the question is a smaller bore tube just as effective as a large bore tube? Now, why would you want to do a small bore tube? Because it's smaller and easier to put in, especially now with ultrasound guidance, and theoretically it should cause less pain because it's not of a big tube. Now, typically when you put it, so just to kind of go over, when you put in a big tube, it's surgically inserted. For me, it's a lot of fun, but it's not fun for the patient, right? Because you have to make an incision, you have to dissect bluntly with a big forceps through muscle, through fat, through tissue, all the way to the rib, then over the rib, poke through into the intrathoracic space, open that up with the forceps, and put the tube in, and the tube is big. That is very painful. That hurts a lot, right? And so a smaller bore tube and that's blunt. There's no ultrasound guidance. With a small bore tube, you can find with ultrasound where the fluid and where the blood is, and then with a small needle, put a wire through the needle, and then the catheter over the wire. It's much easier. And it's much easier on the patient. Anecdotally, when I put in small bore tubes, it's much easier and much more comfortable for the patient than large bore chest tubes. And people who have heart surgery, they also have large bore chest tubes, and it's very, very painful because they're huge tubes, right? So this study showed, it was a systematic review, and they included 11 studies in their review. 3 of them were randomized controlled trials. 3 of them were prospective cohort studies, meaning they just looked at a group of patients prospectively, and 5 were retrospective cohort studies where they looked back. Okay? And they had a total of 1,847 patients and 1,972 tube thoracostomies. So 730 of them were small bore and 1,242 were large bore. Okay, so what they found was there was no significant difference in the failure rate between small bore and large bore tubes. The small bore had 17.8% failure rate, and the large bore tubes had 21.5% failure rate, and this was not statistically significant. Interestingly, however, they found that small bore tubes required less thoracoscopic surgery than large bore tubes, which I thought, and that was statistically significant. I thought that was very interesting. There was no significant difference in mortality or complication rates between the two, but this was also surprising for me, that there was a significant difference in the initial drainage. For small bore tube, the initial drainage was kind of around 753 mLs versus a large bore tube, 398 mLs, and that was statistically significant. And they also had less tube days with a small bore tube, 4.3 versus 6.2. That was also statistically significant. Sorry. Another finding that they found was that they had a higher, small bore tubes did have a higher rate of insertion-related complications, which is interesting. If it's done under ultrasound, that would be very interesting. And some of these complications For a small bore tube includes, bleeding requiring surgical control, intrahepatic placement if you put it into a liver, which is possible, placement through the spleen, which is also possible, puncturing the heart, and then technical failure requiring conversion to a large bore tube, and then also malpositioning and dislodgement. And then complications for large bore tubes includes bleeding requiring surgical control, intrahepatic placement as well, malpositioned tube, dislodgement, and kinked tube. And these you would think conceptually that they would be more common because it's done blind. Again, it's not under ultrasound guidance. The finding about pain, you would think that the small bore tubes would have less pain. It's interesting. One study found that there was less pain. Another study found that there was not less pain. So, and then when they did the meta-analysis between small bore and large bore, they found that there was no significant difference in failure rate, complication rate, mortality rate, ICU length of stay, or hospital length of stay. And then when they did the cumulative analysis with the meta-analysis, they again found that small bore tubes had higher initial drainage than large bore tubes, and then less tube days as well. And it's interesting that the large bore tubes were typically done right away, but the small bore tubes were electively placed about a day later, right? So overall, the findings of the study are quite interesting. I would think that you would just always use a large bore tube if you're dealing with a hemothorax, but this review and meta-analysis shows that no. In fact, in some cases, or maybe we start off with a small bore tube because the literature and the data show that they drain more and they stay in for less, and less patients who get a small bore tube need thoracoscopic surgery. So now, obviously, there are caveats to these findings because even though that the small bore tubes had less tube days, it did not translate into shorter ICU or hospital length of stay. And that what they said and what they speculated was that because this was likely other to secondary or other concomitant injuries, right? And other caveats is that, again, there was conflicting data about pain. Small bore tubes did have a higher rate of insertion-related complications, which for me was interesting. If you do it under ultrasound, that should theoretically be less. But in their conclusion, they say, based on the outcomes of I'm quoting here, based on the outcomes of the study, it may be appropriate to use small bore chest tubes, such as a pigtail, in a select group of patients who have a hemothorax instead of a large bore tube, with the caveat that further data are required in hemodynamically unstable patients and in those with complex thoracic injuries. Consequently, for most patients requiring emergent chest drainage for hemothorax, large bore tube remains the standard. Now, this makes, and then another limitation is that not all of the data are randomized trials. Right, only 3 of the 11 that they reviewed were randomized trials, and that's interesting. If somebody comes in with a hemothorax and they're in hemorrhagic shock, I mean, you can get a large bore chest tube very quickly. You just make an incision, you find the rib quickly, you poke through, open, and drain the blood, right? Whereas a small bore tube with cellular technique, you have to find sometimes you may not even have time for ultrasound, but still you have to put a needle, find it, put the wire in, take the needle out, then put a dilator over the wire, and then put the catheter over the wire. That takes longer, and if somebody who's really bleeding out in their chest, that might be too long. And so, again, even though this meta-analysis showed that small bore tubes may be better and have better drainage and less pain and stay in less, the question remains, and the study doesn't answer that, whether you can do that in a hemodynamically unstable patient. And for now, if it's not needed emergently, the last sentence of the trial says, for now, we recommend considering placing a small bore chest tube in patients who do not need it placed emergently. And so this is very interesting. And again, it's interesting how, what you would think in your common sense, when it's scrutinized by the data, the data do not bear them out. And so this is why it's very important to try as best we can to look at what does the data say. I always roll my eyes at the data people, but you know what? And COVID taught me that I think looking at the data and see do the data support what you do is if possible is quite important, so that we're always practicing evidence-based medicine and not eminence-based medicine. Thanks so much, guys, for your time and attention. Until next time, this is Hassaballa on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.